Hi guys, and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're pretty much going to be looking at commonly used antibiotics in the hospital. I know this is a topic where many medical students, many newly graduated doctors have a lot of challenges with. And from all the different people I've interacted with, one thing has been very evident. Most of them have no idea about the dosages of these drugs. Most of them have no idea when to use these drugs. Therefore, I did come up with this collection of literature that I went over to actually look at the commonly used antibiotics. Of course, you have to note that this is not an exhaustive list. The depth of literature is actually quite deep. There is so much more that you actually need to learn, and take into account that we're not going to be looking at the pharmacological principles in detail because this is not a pharmacology class. So I presume you have ideas of that. If you have no ideas of that, then you should revise. We will put out some lectures on pharmacology on the channel later on. So let's dive into the lecture and see what is there. So remember that antibiotics are pretty much going to be commonly used throughout every hospital in the country, worldwide even. And antibiotics are actually one of the drugs that are going to be abused by many clinicians. They're going to be abused by the general population. Why do I say so? Someone gets a common cold, which is caused by a viral infection. What do? They decide to go get an antibiotic. Now, is that antibiotic warranted for that cold? It may not be. And because of this misuse of antibiotics, there are some side effects that people may actually sustain. There is what is referred to as antibiotic resistance, where the microorganisms now fail to respond to this certain antibiotics. And then before you actually start prescribing these antibiotics, take note that no single antibiotic cures every infection. So there's no one magic bullet that's going to be killing everything, or no one such drug that you can prescribe for everything. It's different antibiotics working for different things. Of course, there are some antibiotics that have more uses than others. Others have less uses than others. Of course, I will point those out and it will be evident by the end of this lecture. So please make sure you watch this video till the end. If you haven't subscribed, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment. And what you also really need to note about antibiotics is that they must always be guided by sensitivity patterns. So we don't just give antibiotics like it's witchcraft or we are just guessing. We use intuition. You should always get a culture for antibiotics. If you don't have the facilities to get a culture, then give the antibiotics which you think are most going to be effective or most likely going to be effective for this patient, depending on whatever condition they're presenting with, depending on the organisms that you think may be affecting these individuals. Now, the antibiotics are largely going to be divided into two main classes, or pretty much two main activities. They can either be bactericidal, meaning that they're going to be killing the microorganism, or they can be bacteriostatic, meaning that they're going to be inhibiting the reproduction and the growth of the microorganism. Now, remember that these antimicrobials, these antibiotics are going to be targeting bacteria. So they're not going to be so useful against viral infections. Some may actually be used against protozoal infections and other types of infections, but viral infections, because remember, antibiotics are not going to be so useful against viral infections. Now, there are some conditions that may require you to actually get a consult from infectious disease unit. So it includes things like septic shock, bacterial stream infections, which could be as a result of catheters, Staphylococcus aureus infections, Candida species, endocarditis, meningitis, encephalitis, brain abscesses, trypanosomiasis, necrotizing skin and soft tissue infections, osteomyelitis, prosthetic joint infections, if you have pyrexia of unknown origin or fever of unknown origin, if you have restricted use of drugs or even they are not so available, for example with vancomycin and meropenem, the much more stronger drugs, then you'd have to consult the infectious disease unit. And of course, if there is an infection in a patient that had a transplantation, if a patient has recently traveled, if there's a suspected outbreak of diseases, resistant organisms like methicillin-resistant Staphylococcus aureus, MRSA, gram-negative resistance to third-generation Cephalosporins or Carbopenems, multi-drug resistant and extreme drug resistant TB. Antibiotic durations, if you're not so sure when to start or to stop, consult infectious disease unit. Then of course, if you have atypical or refractory or even difficult to treat infections, as well as infections with high risk of transmission like cholera, typhoid fever, viral hemorrhagic fevers, Neisseria species, and even rabies. These are just a few of the things that you must inform infectious disease unit and actually have a consultation from infectious disease unit. Now, what are some of the principles of giving antibiotic or prescribing antibiotics? There's some things that you must follow and ensure that you tick all these boxes for safe use of antibiotics. So the first thing is that there must be an indication for why you're using that antibiotic. Do not just prescribe antibiotics because the patient is admitted to the hospital. Do not just prescribe antibiotics because you just saw one thing. So there should be a constellation of things that are pointing you towards a focus of infection. So it could be that this person has a fever. It could be that this person has leukocytosis, of course, with neutrophilia, which is pointing you towards bacterial infections. There could be a raise in inflammatory markers like C-reactive protein, ESR. There could also be some specific organ dysfunctions like they present to you with tachypnea, dysuria, inflamed skin, and even visible infections that can be seen on the skin and soft tissue. Now, all these things must be put together, and you use all this information as a whole pretty much to now decide whether this person needs an antibiotic or not. Now, if you deem that they need an antibiotic, then you must try at all times to actually collect samples that you're going to be taking for culture, microscopy, and sensitivity, especially sensitivity, because you should have an idea of which organisms are actually going to be affected by a certain type of antibiotic, such that if this person isn't responding to the drug that you have given them, then you can switch to another drug which is found to be sensitive due to your sensitivity reports, and this can actually help the patient. But never should you wait to get a culture and delay the treatment of the patient. So treatment must not be delayed when you want to get a culture. You must ensure that this patient receives treatment at the right time. Then of course, there should be the right choice of empirical antibiotic treatment. So if we don't have the facilities for culture, or we don't have enough time to wait for the culture, then you can pretty much start on your empirical treatment. So this empirical treatment is going to be based on certain things. So it's going to be based on what is most likely causing this infection. So what is the pathogen that you are trying to target? What's the site of infection? You should assess the likelihood of resistance, because there are some antibiotics that have now become resistant, or rather some bacteria have now become resistant to certain antibiotics. So even if you give this antibiotic, you're pretty much going to be wasting your time. Then of course, you should review any potential contraindications for certain drugs, because some drugs are not given in pregnant women, they're not given in lactating mothers, they're not given in neonates. Then of course, there are some drug-to-drug interactions, because some patients may be taking other drugs that may either affect the concentration of this antibiotic in the blood, or the excretion of this antibiotic from the body, as well as even the absorption of the antibiotic from the route of administration. And of course, you should choose the right drug based on how well it's going to be penetrating the different types of tissues, because different types of tissues have different penetrating abilities. Then of course, aim for a single drug that has a desired spectrum of activity. If you have no such drug, then you can combine some drugs. Then of course, you should have the right dose and the route of administration. You should start the appropriate antibiotic therapy rapidly in severe infections. Then of course, you should remove any source of infection, control the source of infection. If there is pus that is collected somewhere, make sure that you drain that. If it's an abscess, make sure you drain it. If it's empyemothoracis, make sure you remove that pus from the thoracic cavity using your ICD. Then of course, every single day that you see the patients, you must review your antibiotics. So you should review, am I giving the right delivery system, the right route of administration? Can you switch them from IV to oral if they can tolerate? Then of course, the dose, which is based on the weight of the patient, the estimated glomerular filtration rate, and of course the correct intervals, the times in which this patient must receive this drug. The duration of the treatment, of course, depends on the infection that is there, and of course the ability to de-escalate, because sometimes you may start off what is referred to as blind treatment, where you give something that is very strong and covers a lot of things, and then when you get your sensitivity report, you find out that there's a much more narrow drug that you can give that's just going to target this organism that's causing this illness. Of course, you can de-escalate these antibiotics in such a case. So you should make sure that you tick all these boxes. And once you tick all these boxes, it makes antibiotic prescription very, very easy and, of course, very, very effective. Now, here's a schematic, or rather an algorithm, to show you about prescription of antibiotics. So let's say a patient comes in, you collect your specimens based on the clinical presentation. Then, of course, you start the patient on empirical antibiotics. So there are two outcomes that could happen. So the patient could clinically improve, or they won't respond, or they'll have a slow response over 48 to 72 hours. Then, of course, if they clinically respond, if this is empirical treatment, then, of course, if your culture and sensitivity has isolated the bacteria, you can de-escalate the antibiotic and actually give the narrowest spectrum antibiotic, and which is more effective. You can switch from IV to oral. Then, of course, if the bacteria is not identified, then you complete the course of that same empirical treatment that you already started with. Of course, if this is a definitive treatment, then, of course, continue and complete the course. Now, on the other hand, if they don't improve, then if the culture and sensitivity results are present, it could mean that there's one of three scenarios. It could mean either that it's the right organism and you're given the right drug, or it's the right organism, you identified the right organism, but you've given the wrong drug, or you don't know the organism and the drug that you're giving is quite questionable. So if you're given the right organism and the right drug, it could mean that maybe you're not giving the drug. There's a collection of pus somewhere that needs to be drained, or you need some imaging to locate it so that it's drained. For example, if you have an abscess of some sort, it has to be drained. Then if there's inappropriate delivery, for example, poor absorption from the mouth, then you have to switch them to IV. If there's inappropriate dosage, where you have to give them a much higher dose, especially for the deep-seated infections like in the endocardium as well as in the bone. Then, of course, if they have any other comorbidities that can actually explain the symptoms, like, for example, immunosuppression, or there is inappropriate expectation. So some infections actually take much longer to respond to the antibiotics than others. Then, of course, if you're given the wrong drug for the right organism, then, of course, you have to change to the appropriate antibiotic based on the culture results, and then the patient will respond. Then, of course, if the organism is not known and the drug is also questionable, then you should consider some risk factors for specific microorganisms. For example, in patients that are admitted to the ICU, they're prone to actually having Pseudomonas aeruginosa as well as Actinobacter species. So give drugs that are going to be targeting these organisms. We'll have a look at them. Then, of course, with diabetes, then give Candida species are much more common in patients with transplants and over 50 years, patients with cancer. Listeria monocytogenes. New onset diarrhea in hospitalized patients is most obviously due to Clostridium difficile, which is usually associated with antibiotics. Then, of course, HIV, you should consider TB and other opportunistic infections. So this is the schematic that you're going to be following every time you start antibiotics, together with what I showed you on the previous slide. So keep that in mind because it's very, very important. I'm not just going to jump right into the drugs and give you the dosages. I want you to learn even the principles so that you make an effective professional. So you ask, how long are we going to be giving these drugs? Of course, this is a basic guide. We will cover most of these conditions on the channel eventually. So whenever we reach that slot of infectious diseases, I will mention the antibiotics that you can use, the dosages and the timings and intervals. So this is like an overview, a summary of everything that we will talk about on the channel. Lord knows when we're going to finish all the topics. Then if it's asymptomatic bacteriuria, there's no need for you to actually give antibiotics unless otherwise, or there's anything else. If it's bronchitis, of course, also no need for antibiotics unless otherwise. Then if there's intra-abdominal infection with a source control, or you have controlled the source of infection, then about 4 days. If it's an acute exacerbation of chronic bronchitis or a COPD, 5 days or less. If it's acute bacterial sinusitis, pneumonia, which is usually community acquired, cellulitis, hospital acquired, cellulitis, these are all given for 5 days. Then with hospital acquired pneumonia, as well as ventilator associated pneumonia, pyelonephritis, as well as uncomplicated gram-negative bacteremia. I don't know what's happening to my English. It should be given for 7 days. Then if it's gram-negative bacteremia, 14 days. If it's uncomplicated, you give it for 7 days. If it's pretty much complicated, 14 days. Others could even go much further than this. Then, of course, uncomplicated gram-positive bacteremia, which is non-Staph aureus and non-Staph that 7 days. If it's infective endocarditis, 4 weeks plus. Then osteomyelitis, more than 6 weeks. So this is just like a basic guide that you're going to be using to determine your duration of antibiotics. But rule of thumb, generally, we use either 7 to 10 days. Sometimes we can go up to 10 to 14 days. Sometimes you may even reach 21 days. Sometimes you may reach a month. Sometimes even 6 weeks. That's now largely dependent on whatever is causing the illness, whatever is causing the sickness. Now, what are some of the common organisms that you need to worry about? Because we'll mention some of these organisms along the way. So, 4 main groups: the gram-positives, the gram-negatives, the anaerobes, and the atypical bacteria. So, the gram-positives, your Strep group A, B, C, and G, your Streptococcus pneumoniae, your viridans Streptococcus, your Streptococcus milleri, your Enterococcus faecalis, Enterococcus fecum, Staphylococcus aureus, Staphylococcus epidermidis, Corynebacterium, Listeria monocytogenes. Then, of course, the gram-negatives, you have your Neisseria, gonorrhea and meningitis, Moraxella catarrhalis, Haemophilus influenza, E. coli, Klebsiella species, Enterobacter, Salmonella, Shigella, Proteus, and so on and so forth. Pseudomonas is also quite important. Then the anaerobes, you have actinomyces. The bacteroids, you have Clostridium difficile, Peptostreptococcus species. These are just some of the examples of anaerobes. The atypical organisms like Chlamydia species, Mycoplasma pneumoniae. So keep these organisms in mind, because there will be times when I tell you that this drug is effective against gram-positives only, or gram-positives and negatives. It's effective against anaerobes only. Like, for example, with metronidazole or metronidazole, however you pronounce it, it's pretty much going to be effective against anaerobes. Okay, so here is a very high yield table based on the information that's gotten from the current guidelines or antibiotic prescription from, of course, infectious disease UTH in Zambia. So here are the different classes that we'll look at. You have penicillins, cephalosporins, carbopenems, aminoglycosides, fluoroquinolones, macrolides, lincosamides, oxazolides, glyco and lipos. You have tetracyclines, polymyxins, and others. And of course, penicillins, you have the different drugs that are listed there. Cephalosporins, you have the different drugs that are listed there, and so on and so forth. Now, I want you to take some time to actually look at this diagram. I will leave a link in the description below with this PowerPoint presentation that I will upload to my Dropbox. So find some time to actually download this PowerPoint and actually watch it. I will leave a link in the description below. So the green pretty much just symbolizes that these drugs are effective against this organism. So let's take one of the most commonly used antibiotics. Let's take Ceftriaxone, for example, which is over here. So Ceftriaxone works against Streptococcus species. It works against MRSA. It doesn't work against these species. The red, it means it doesn't work. So it's not going to be effective against MRSA, Enterococcus faecalis, Enterococcus fecum, and so on and so forth, Pseudomonas and friends. But it will work against these Salmonella species. It will work against Shigella species. It has sometimes works against Enterobacter species. E. coli doesn't work, especially this strain. Then some other strains of E. coli, it does work. The anaerobes, it doesn't work. Atypical bacteria, it doesn't work. So this is just simply to have an idea of sensitivity patterns. These things obviously do change from different hospital to hospital. They do change from different country to country. So this is based on the findings that were done at UTH, and this is what we're using as a country, because this is a similar pattern is seen in the country. But of course, there are some subtle differences when you come to different hospitals and different places. So just keep this diagram in mind, or take a screenshot of this diagram because it may help you. Now, what are some of the common classes of antibiotics? So they fall in different classes based on their chemical structure. They fall in different classes based on their pharmacological properties. So some important classes are going to include things like cell inhibitors, which could be penicillins, plus beta-lactamase inhibitors, cephalosporins, carbopenems, and monobacter. These are pretty much going to be inhibiting cell wall synthesis. And of course, you have protein synthesis inhibitors like tetracyclines, aminoglycosides, macrolides, lincosamides, this that I'm not going to attempt to pronounce, and others. Then, of course, you have antimetabolites and nucleic acid inhibitors like fluoroquinolones, inhibitors of folate reduction, combination of inhibitors of folate reduction and synthesis. Then, of course, you have urinary tract antiseptics. So these are the common classes of drugs that we use as a country and in different hospitals. And of course, you will find this as a list that's not so exhaustible, but very, very helpful, especially when you are starting to work. So here's a diagram and a schematic to help you remember the different classes of antibiotics. So here you have the inhibitors of cell membrane function, the isoniazid, amphotericin, and polymyxins. I won't discuss any of these because we'll discuss them in the different topics on the channel. Then we have inhibitors of nucleic acid function of synthesis, fluoroquinolones and rifampicin. We'll discuss fluoroquinolones. We have inhibitors of protein synthesis, tetracyclines, aminoglycosides, and all these other drugs. We'll discuss all these drugs. Inhibitors of cell wall synthesis, the beta-lactams, the vancomycin, daptomycin, and so on and so forth. Here, I think I only discussed about beta-lactams, which are the penicillins, cephalosporins, and carbopenems and friends. Then, of course, the inhibitors of metabolism, sulfonamides and trimethoprim, which I think I discussed, trimethoprim and sulfamethoxazole. So we'll start with cell wall inhibitors. Now, remember that bacteria have a cell wall. Humans do not have a cell wall. Human cells do not have a cell wall. So these drugs are going to be working by inhibiting the synthesis of the bacterial cell wall, which is the only component that's only found in bacteria cells, as opposed to not being found in human cells. Then, of course, how do these work? They're pretty much going to be inhibiting the formation of the peptidoglycan, which consists of glycan units joined to each other by peptide cross links. So this shouldn't be sounding like Greek to you. In short, they pretty much inhibit the synthesis of the cell wall. Remember that the cell wall is what offers the protection of the bacteria against osmotic pressures from it being killed when water flows into it. Then, of course, the maximum effect that we see is when we use these drugs against organisms that are actively proliferating. So these drugs are not going to have any effect, or they're going to have little effect against bacteria that is not growing and that's not dividing. So the common classes include penicillins plus beta-lactamase inhibitors. There are some drugs that you can give to augment the functioning of certain penicillins. Then you have cephalosporins, you have carbopenems, and as well as monobacters. So we'll start with penicillins. Now, these drugs are bactericidal, and they're going to be effective against rapidly growing organisms, and these organisms that synthesize the peptidoglycan. Now, with these penicillins, they tend to diffuse very well into body tissues and fluids, but they penetrate into the CSF very poorly, except when the meninges are inflamed. So it means that if someone has a CNS infection, penicillins would be good for them. Then these penicillins and pretty much the cephalosporins and other related drugs that are beta-lactam drugs have a high risk of hypersensitivity reactions. So there are some people that are allergic to these drugs. So they may develop rashes, they may have anaphylaxis, they may have immediate hypersensitivity where they go into shock. They have some bronchospasms and cardiovascular collapse. They can actually die. And of course, diarrhea is also another common side effect. So patients actually that have a history of hypersensitivity to penicillins must not be given cephalosporins because there is a high chance that they will react to these cephalosporins. Then, of course, the higher doses than usual of penicillins, then even normal doses can actually mess around with electrolytes and result in accumulation of certain electrolytes because these drugs tend to have some sodium, they tend to have some potassium attached to them. So you give these drugs, you get an increase in potassium levels, increase in sodium levels. So the common drugs that we will discuss are amoxicillin, ampicillin, penicillin G, penicillin V, and flucloxacillin. So we'll start with ampicillin. So this is pretty much going to be a broad spectrum penicillin that's going to be working against gram-positive and gram-negative organisms. It's pretty ineffective. It doesn't work against organisms that produce the penicillinase enzymes. There's one penicillinase enzyme which is known as the beta-lactamases, which pretty much breaks down the beta-lactam ring. Remember that the beta-lactam ring is pretty much the ring that's going to be the active ingredient of the penicillin. So once you break that down, you render the drug useless, and that's how these bacteria actually develop resistance. That's one way in which bacteria can develop resistance. Another way in which bacteria can develop resistance against drugs is sometimes they can make these channels that actively pump out this drug out of the bacteria. So it's kind of like you shoot someone with a bullet, they catch the bullet and throw it back at you. That's how resistance works in layman's language. Then of course, so it's not going to be working against Staphylococcus aureus as well as some gram-negative bacilli like E. coli strains that are pretty much going to be producing these enzymes. So about 60% of E. coli, 20% of Haemophilus influenza strains, and virtually almost all the Staphylococcus strains are now resistant to ampicillin. So that's why we do not want to use this drug as blind treatment without checking any sensitivity. So here is the antimicrobial spectrum of penicillin. So it can work against gram-positive cocci like Enterococcus. It can work against gram-positive bacilli like Listeria monocytogenes. It can work against gram-negative rods like Escherichia coli, Haemophilus influenza, though there is some resistance that we've noted with this of late, Proteus as well as Salmonella typhi. Then of course there is some activity against anaerobic organisms, spirochetes, mycoplasma, chlamydia, and as well as others. So what are some of the indication of the drugs? If someone has exacerbation of chronic bronchitis with middle ear infections, you have also with Streptococcus pneumonia as well as Haemophilus influenza infections, oral infections, uncomplicated community-acquired pneumonias, and even urinary tract infections, then you can give this drug. Now, this drug can be administered orally. It can be administered via an intravenous infusion or an intravenous injection. It can be administered via an intramuscular injection. So if you're giving it orally, you should give it at least 30 minutes before food. So the dose is about 250 milligrams to about a gram. You can give this orally 6 hourly. So you give it at 6 hourly intervals. So if we count 6 hourly, it means that you would give this drug 4 times a day. So it's 250 to about a gram, 1000 milligrams, 4 times a day, QID. You can give it at 500 to 1000 milligrams, 4 to 6 hourly. You can give this IV or IM for endocarditis. If you're giving an infusion, you can give 2 grams every 6 hourly, increased to 2 grams every 4 hourly if you are suspecting that there's an enterococcal endocarditis. Then of course if ampicillin is being used alone, then of course you can give 2 grams IV infusion every 4 hours in Listeria meningitis in combination with another antibiotic. Then moving on to the next drug, which is amoxicillin. This is used in oral infections as well as Helicobacter pylori eradication. So it's used in some regimens for triple therapy against Helicobacter. It has similar antibacterial spectrum as compared to ampicillin, but it's better absorbed orally. It is often combined with a drug that augments its action, which is known as clavulanic acid. So it's known as co-amoxiclav. So the clavulanic acid is pretty much going to be inhibiting the beta-lactamase enzyme such that it will render this drug much more effective against strains that produce this enzyme. So against strains like Staphylococcus aureus, E. coli, Haemophilus influenza, as well as some bacteroids and Klebsiella species. Now, how do we give this drug? 250 milligrams every 8 hours, so 250 milligrams 3 times a day. You can double the dose in severe infections. But of course, if they have a pneumonia, you can give 500 milligrams to 1 gram 3 times a day. Then of course, if you're giving it as an intramuscular or IV injection, intramuscular, you can give it at 500 milligrams every 8 hours or 3 times a day, and you can increase this to about 1 gram every 6 hours or 4 times a day as an IV infusion or injection in patients that actually get the severe infections. Then the next drug is of course your penicillin G. Now penicillin G is called by another name. So penicillin G can also be referred to as Cristopen. It's going to be effective against gram-positive bacteria. It's going to be effective against gram-negative cocci, and it's also going to be effective against spirochetes. It's going to be effective against actinomyces. Then it's going to be ineffective against many streptococcal infections, including pneumococcus. Effective against streptococcal infections. It's going to be effective against gonococcal infections. It's going to be effective against meningococcal infections. So it can be used for pneumonias. It can be used for gonorrhea. It can be used for meningitis. Then, of course, You can also use it in other conditions like anthrax. You can use it in diphtheria, gas gangrene, leptospirosis, and even in the treatment of Lyme disease. So although it is actually quite effective when you are using it in the treatment of tetanus, metronidazole is actually the preferred agent. Then of course indications would mean things like throat infections, otitis media, endocarditis, meningococcal disease, pneumonias. You may also have cellulitis, abscesses, bites and stings, anthrax, as well as prophylaxis in limb amputations. So the sensitivity, what we've noted is that the sensitivity patterns have reduced due to bacteria actually producing the beta-lactamase enzymes. And of course, when you give it to treat syphilis, there is a risk of actually having what is known as the Jarisch-Herxheimer reaction. I want you to read up on that. And if you know what it is, please comment in the section below about the Jarisch-Herxheimer reaction. And of course, the route of administration is going to be given as pretty much an injection, because if we give this drug orally, it's not so stable, so the absorption from the gut is very low. So this drug is best given as an injection. So we can give it at a dose of 2.4 to 4.8 grams daily in 4 divided doses. Now this is a different concept that I've given you here. Remember when we were talking about amoxicillin, we said we can give it 4 times a day. So it means that if you're giving 500 milligrams 4 times a day, with each dose, a patient is receiving 500 milligrams. Now, this is not the same thing as in 4 divided doses. So you're going to give a maximum of 2.4 to 4.8 grams per day, and you can divide this total in these 4 equal doses. So you can give this as an intramuscular injection or a slow IV injection or an infusion in adults. And of course, we can increase in severe infections. And remember, any single dose that's above 1.2 grams must be given as IV only. Then of course, the dose is adjusted according to the condition. You may get some conditions like endocarditis, which warrant very high doses like 7.2 grams per day in 6 divided doses, or up to even 14.4 grams per day in 6 divided doses when you use this drug alone. Or even in meningitis, you can give it at 2.4 grams every 4 hours. And then here are some of the therapeutic applications of penicillin G. So remember, it's going to be effective against gram-positive cocci like Streptococcus pneumoniae, Streptococcus pyogenes, Streptococcus viridans group. It's effective against gram-positive bacilli, but you get some resistant strains with Streptococcus pneumoniae. It's effective against Bacillus anthrax as well as Corynebacteria diphtherium. It's also effective against gram-negative cocci like Neisseria gonorrhea and Neisseria meningitidis. It's effective against your anaerobic organisms like Clostridium perfringens, as well as some spirochetes like Treponema pallidum, which is causing syphilis. And then, of course, even some action against Mycoplasma, chlamydia, and other bacteria infections. And of course, it's effective against treating pneumococcal infections. It's effective against treating your gonorrhea infections. It's effective against penicillins. In penicillins, usually a single treatment with penicillin is going to be curative for primary and secondary syphilis, and no antibiotic resistance has been reported, though we are still having some concerns coming up. Then, of course, it can be used for gonorrhea. Remember that in babies that are born to mothers that have gonorrhea, we want to use silver nitrate eye drops to prevent, of course, ophthalmia in the newborn. Then some strains produce penicillinase enzymes. We should treat them using your Ceftriaxone as well as azithromycin or spectinomycin as a backup. Then, of course, with Streptococcus pneumoniae, this is a major cause of pneumonia in all the different types of age groups. And then, of course, resistance to penicillin G has been seen in some countries. Then we'll move on to the next drug, which is penicillin V, which is also known as phenoxymethylpenicillin. So this is why it's abbreviated as penicillin V, because not so many people are going to remember phenoxymethylpenicillin. So this has a similar antibacterial spectrum similar to benzopenicillin, but is less active. And the route of administration, this is actually more stable to the acid, and it is going to be suitable to administer orally. So it should not be given in serious infections. Why we don't give this in serious infection? Because remember, oral absorption from the gut is not predictable. You get different varying concentrations of plasma with different drugs. So that's why we don't give this drug in serious infections. We usually limit it to some oral infections, otitis media, erysipelas, cellulitis, Group A, streptococcal infections. You may even give some respiratory tract infections. In children, streptococcal tonsillitis for continuing treatment after one or more injections of benzylpenicillin when you get a clinical response. You may also give it in prophylaxis against streptococcal infections in following rheumatic fever. You may also give it in pneumococcal prophylaxis in patients that have had splenectomy or in patients with sickle cell disease. Now, we do not use penicillin V in treating meningococcal and even gonococcal infections. We can give it at a dose of 250 to 500 milligrams every 6 hours. So it means that this is going to be given 4 times a day, and you can increase this to 1 gram 4 times a day in severe infections. In neonates, you give it at 7.812 milligrams per kg every 6 hours or 4 times a day. In pediatrics, you give it at 12.5 milligrams per kg every 6 hours. So note that for some of the drugs, I'm going to be giving you the dosages that you give in neonates. For some of the drugs, I won't give you the dosages because this is mainly focused on the adults. Pediatrics also has its own dosages, of which we will cover in the section of pediatrics. Then, of course, the other drug is known as flucloxacillin. So remember that most staphylococcus are now resistant to benzylpenicillins, and because they're going to be producing the penicillinase enzymes. Now, flucloxacillin is not inactivated by these penicillinase enzymes, and so it can actually be used in the treatment of this penicillin-resistant staphylococcal infections, which is usually the only indication for us to use flucloxacillin. So it's also acid stable, so it can be given orally. It can also be given as an injection. So it's given in treatment of otitis externa. It can be given as an adjunct in pneumonia with other drugs. It can be given in treatment of impetigo, cellulitis, osteomyelitis, and even staphylococcal induced endocarditis. Then, of course, this drug must be used with caution in neonates because it has the potential of causing kernicterus. Now, what's going to be the dose of this drug? Orally, you can give 250 to 500 milligrams every 6 hours. So that means about 4 times a day, at least 30 minutes before food. And as an intramuscular injection, you can give 250 to 500 milligrams every 6 hours. So that's 4 times a day, QID. Or as an IV injection or an infusion, you can give about, this is supposed to be 0.25, not 0.25. So this is 0.25 to 1 gram every 6 hours. In osteomyelitis, you can even give up to 8 grams daily in 3 to 4 divided doses. So that's all about penicillins. Now we move to the next group of drugs, which are the cephalosporins, which gave headache to everyone in pharmacology about learning the different generations of cephalosporins. So these are a very, very large group. Actually, these are the most widely used, together with the penicillins, the most widely used drugs in the hospital, I can guarantee you. Now, they are broad-spectrum antibiotics that are going to be used in the treatment of septicemia, in the treatment of pneumonia, in the treatment of meningitis, biliary tract infections, peritonitis, and even in urinary tract infections. This is tract, not treat. So they're going to be penetrating the CSF poorly normally, unless if the meninges are inflamed. Just like with penicillins, they can be used in the management of meningitis. Now, your drug of choice that's going to be suitable for CNS infections is actually Cephalotaxim. And these drugs, just like with the penicillins, also carry the risk factor of having hypersensitivity, and they are divided into generations: first generation, second generation, third generation, and fourth generation. I'll just talk about the first, second, and third because those are the drugs that we commonly use. One drug that we commonly use from the first generation is Caphylexin. A drug that we commonly use from the second generation is Ceftriaxone. And drugs that we use from the third generation include Ceftriaxone, Cephalotaxim, Ceftizodine, as well as Suffixesin. Okay, learn these drugs and how to pronounce them and their dosages. So here's the therapeutic applications of these cephalosporins. So the first generation are going to be effective against gram-positive cocci like Staph aureus, but there is some resistance now. Staphylococcus epidermidis, Streptococcus pneumoniae, Streptococcus pyogenes, and aerobic streptococci, as well as some gram-negative rods like Escherichia coli, Klebsiella pneumonia, and Proteus mirabilis. Then, of course, second generation cephalosporins are effective against the gram-positive cocci, which is a similar profile to the first generation cephalosporins. The only difference here is that these are not going to be so effective against your Staphylococcus epidermidis, which I can see on this list. Then, of course, you have your gram-negative cocci in addition, which is going to be effective against Neisseria gonorrhea. And then, of course, gram-negative rods like Enterobacter, Escherichia coli, Haemophilus influenza, Klebsiella pneumoniae, Proteus mirabilis. Then, of course, your third generation cephalosporins is going to be working against your gram-positive cocci, just similar to this profile. Your gram-negative cocci, which is also similar to this profile, and your gram-negative rods, which is also similar to this profile. So keep these names of these organisms and the drugs that are targeting these organisms in mind, together with the dosages, of course. So here is another thing on the therapeutic application. So with the different generations. So we have the first generation like Cephazolin and Caphylexin. So this is the first generation cephalosporins. It has a very long duration of action and a similar spectrum of action compared to other first generation drugs, and it penetrates into the bone quite well. Then, of course, the Caphylexin is the prototype of the first generation oral cephalosporins. It's given orally twice a day, which is effective against a pharyngitis infection, for example. Then, of course, you move to the second generation where you have your Ceftriaxone. You can have your Ceftriaxone sodium or this other preparation here. So this is the prototype. The Ceftriaxone sodium is the prototype that is there. It can be given parenterally. It has a longer half-life than other agents, and it can cross the blood-brain barrier. So it can be used for community-acquired bronchitis, community-acquired pneumonias, as well as pneumonias in the immunocompromised. Then, of course, this other formulation here can be given twice a day and is absorbed very well, and it's effective against organisms that produce beta-lactamase enzymes. Then, of course, you have the third generation cephalosporins like Suffixesin, which can be administered orally once a day, Cephalotaxim, which penetrates quite well into the CSF, Ceftizodine, which is active against Pseudomonas aeruginosa. You also have Ceftriaxone, which, of course, has the longest half-life of any cephalosporins, up to like 6 to 8 hours, and it permeates once a day usage. And then, of course, high levels of the drug can be achieved in the blood, as well as high levels can be achieved in the CSF, which is why this drug is quite extensively used in the hospital. As I'm sure when you go to the hospital and visit any hospital, this is one of the common drugs that you will see being commonly prescribed. And of course, you have the fourth generation, which can be effective against your Pseudomonas aeruginosa. So we'll start with the first generation, which is the Caphylexin, which can be spelled with a PH or an F. So indications include things like infections due to severe gram-positive and gram-negative bacteria, dental infections, genital urinary tract infections, otitis media, respiratory infections, skin and soft tissue infections. So this drug must not be given to pregnant women or neonates unless if the benefits outweigh the risk, but generally they shouldn't be given. Now, how are you going to dose this drug? It can be given as IV, and it also can be given orally. There is an oral suspension that can be given actually in pediatrics. So orally, you can give 0.5 to 1.5 grams every 8 hours, so that's 3 times a day. Or you can give the same dosage IV. You can increase it to 4 to 8 grams 8 hourly, that's 3 times a day IV for the severe infections. In pediatrics, 25 to about 100 milligrams per kg, you give it twice a day orally. Then Ceftriaxone is a second generation cephalosporin that can be used in surgical prophylaxis. It can target Haemophilus influenza and Neisseria gonorrhea, Lyme disease, acute and chronic bronchitis, bone and joint infections, genitourinary infections, gonococcal infections, impetigo, infected wounds, NSAID, associated gastric and duodenal ulcers, otitis media, peritonitis, pharyngitis, pyelonephritis, respiratory tract infections, sinusitis, skin as well as soft tissue infections. Now, this drug can be given orally, it can be given IV, it can be given intramuscular. So we can give it 250 to 500 milligrams twice a day in mild to moderate infections. We should double the dose in severe infection, and this drug must be taken after food for optimal absorption. Then, of course, we can give 750 milligrams in severe infections every 6 to 8 hours, so about 3 times a day. We can give it 3 to 4 times a day, and then 1.5 grams every 3 to 4 times a day in severe infections. And then every single dose that is above 750 must be given IV. You shouldn't give it orally. Then, of course, in meningitic dose is about 3 grams IV every 8 hours, so that's about 3 times a day. Then the third generation cephalosporin is Cephalotaxim, which can work against Haemophilus influenza epiglottitis, meningitis, bacteremia, cellulitis, gonorrhea, gynecological infections, obstetric infections, osteomyelitis, peritonitis, respiratory infections, surgical prophylaxis, and UTIs. This drug can be used also in neonates and pediatric patients, as opposed to you using Ceftriaxone, which has also the potential of causing kernicterus in neonates. So the route of administration is going to be intramuscular and IV. So the dose is 0.5 to 1 gram every 24 hours IM. We can also give in gonococcal infection 1 to 4 grams once a day, or 1.5 to 6 grams if you have resistant organisms. We can give 2 to 12 grams 4 times a day for bone and joint infections, 2 to 4 grams per dose. We can give this twice a day, IM or IV, that's the usual dose. Then for anyone with an intra-abdominal septicemia or endocarditis, we can give 3 to 6 grams per dose every 24 hours. Pediatric patients are going to have a 50 milligrams per kg in 2 to 4 divided doses. You can increase it to 150 or even push it up to 200 in severe infections. Now, you also have another third generation Cephalosporin, which is the most commonly used drug, I think in the country, Ceftriaxone. So this is used for bacteremia, benign gastric duodenal or NSAID associated ulcers, bone and joint infections, chancroid, endocarditis, enteric fever, gonococcal infections, lower respiratory tract infections, Lyme disease, meningitis, pneumonias, surgical prophylaxis. You can use it for syphilis. You can use it for urinary tract, not treat. I don't know why I keep writing treat. Tract infections, skin and soft tissue infections. And of course, it can be given IM, intramuscular, or IV, intravenous. So our usual dose is about 1 gram daily, once a day, or 2 to 4 grams daily in severe infections. So if you're giving over 1 gram as a single dose, you should divide that between more than one site. For example, if you're using the deltoid, you use the deltoid and another site. Then, of course, a single IV dose above 1 gram must be given by IV infusion. For uncomplicated gonorrhea, you can actually give a deep intramuscular injection as a single dose, 250 milligrams, and that's it. Then for meningitis, we use a meningitic dose, that's 2 grams twice a day. And of course, we should avoid this in neonates, like I said, because of the potential risk of kernicterus. Avoid this in pregnant women as well, unless if the benefits outweigh the risks. Then the other third generation Cephalosporin is Suffixesin, which is used for otitis media, pharyngitis, pneumonia, respiratory tract infections, uncomplicated urinary tract infections, and it's given orally 200 to 400 milligrams once a day. Then of course you have Ceftizodine, which is also another third generation Cephalosporin, which is used for bacteremia, biliary tract infections, bone and joint infections, endometritis, ENT infections, GIT infections, gynecological infections, intra-abdominal infections, lower respiratory tract infections, lung abscesses, meningitis, osteomyelitis, pelvic infections, peritonitis, pneumonias, skin and soft tissue infections, as well as UTIs, all of which these many conditions we will cover on the channel. So this is like an overview of everything, the infectious aspect. Of course, there is actually way much more data than I'm actually giving you here on the channel. There are some resources that you can have a look at. You can have a look at the British National Formulation, the updated version. It will give you the dosages of the different drugs and also the different conditions in which you can use these drugs. That's the single most important thing that you must look at. Also look at your hospital guidelines on your sensitivity reports and your antibiotic guidelines from your hospital. Then the dose, of course, of Ceftizodine is 1 gram every 8 hours or 2 grams every 12 hours, or you can give 2 grams every 8 to 12 hours or 3 grams every 12 hours in severe infections. And of course, a single dose over 1 gram must be given via the IV route. Now, that's about it on Cephalosporin. So we move now to the next bit, which are, of course, the Carbopenems. So these are also going to be beta-lactam antibacterial agents, and they have a broad spectrum of activity. So they're going to be effective against gram-positive organisms like gram-positive cocci, Staph aureus, Staph epidermidis, Enterococcus faecalis, Strep A, B, and C, Streptococcus pneumoniae, although there is some resistance of some of these organisms, especially with staph, gram-positive bacilli like Listeria monocytogenes, gram-negative cocci like Neisseria gonorrhea and Neisseria meningitidis, gram-negative rods like Actinobacter species, Citrobacter species, Enterobacter, Escherichia coli, Gardnerella vaginalis, Haemophilus influenza, Klebsiella species, Proteus, Pseudomonas, Salmonella, so on and so forth. Then, of course, the anaerobic organisms like Clostridium species, Peptostreptococcus species, Propionibacterium species. This is actually like Propionibacterium acnes, which actually causes acne. And of course, Bacteroid species and Fusobacterium species, and of course, some activity against spirochetes, Mycoplasma, and Chlamydia, and other things like Actinomyces and Nocardia species. Now, two important drugs here, imipenem and meropenem, which work against Pseudomonas infections. So especially if you're in a hospital where you have a lot of Pseudomonas, you should contemplate using these drugs. So they're not going to be effective against methicillin-resistant Staphylococcus aureus and Enterococcus fecum. Some indications include severe hospital-acquired infections, polymicrobial infections including septicemia, hospital-acquired pneumonias, intra-abdominal infections, skin and soft tissue infections, as well as complicated UTIs. These also carry the risk of hypersensitivity, and they should be used with caution in pregnant, lactating mothers, as well as patients with renal impairment. And of course, the dosages, imipenem can be given at 1 gram to 2 gram daily in 3 to 4 divided doses. Then, of course, less sensitive organisms, you can give up to 500 milligrams per kg daily. So you shouldn't exceed 4 grams in a day in 3 to 4 divided doses as an IV infusion. Then meropenem can be given 500 milligrams every 8 hours. You can double the dose in severe infections. Then moving on to the next, which is the Monobacter. Aztreonam is an example of a monocyclic beta-lactam drug, which has an antibacterial spectrum against the gram-negative aerobic bacteria, including Pseudomonas aeruginosa, Neisseria meningitidis, as well as Haemophilus influenza. This drug should not be used as monotherapy if you're having blind treatment, so it should be combined with other drugs because it doesn't work against gram-positive organisms. It also carries the risk of hypersensitivity, so the dose is going to be given at 1 gram every 8 hours, or 2 grams every 12 hours, or 2 grams every 6 to 8 hours in severe infections, and you give this as an infusion. Single doses over 1 gram must be given via IV route only. So those are the groups of drugs that are pretty much going to be inhibiting the cell wall synthesis. And we're done with them. And I hope you understand about the rough idea of the indications that these drugs are used for, the dosaging, and of course the route of administration. Moving on to the other big group, which is pretty much going to be protein synthesis inhibitors. So these are going to be working to target the bacterial ribosomes or inhibit bacterial protein synthesis. Now remember that ribosomes that are found in humans are going to have a 40S and a 60S subunit, whilst the bacterial ribosomes are going to be having a 30S and 50S. So this, we can take advantage of this because we can make a drug that will only bind to these subunits that are found in bacterial ribosomes. Then of course, common classes include tetracyclines, which includes tetracycline itself, doxycycline, aminoglycoside, azithromycin. This must have been one of the most googled drugs, especially during the pandemic, because it's the drug that most people have been abusing. Clarithromycin as well as erythromycin. You can have macrolides or ketolides like gentamicin, amikacin, and streptomycin. Lincosamides like clindamycin. You can also have linezolid. I'm not going to pronounce this. And of course, other drugs like chloramphenicol. So we'll begin with tetracycline. So this has a quite broad spectrum of activity, and its effectivity has actually reduced because of resistance that we have noted. Now, these drugs are bacteriostatic. Remember that the previous drugs that we talked about are mainly bactericidal, and they're going to be working against organisms that are rapidly multiplying. Now, these, on the other hand, are bacteriostatic, which also means that they're going to be stunting the growth and multiplication of certain bacteria. Now, they're going to be effective against oral anaerobes. They're going to be effective against some gram-positive and gram-negative bacteria. They're going to be effective against some protozoa. They're going to be effective against spirochetes, Mycobacterium, as well as atypical species. And they're going to be commonly used in the treatment of things like acne, chlamydia infections like trachoma, psittacosis, salpingitis, urethritis, and lymphogranuloma venereum, where you use the drug doxycycline. And then other conditions include rickettsia, including Q fever, brucella, where we give doxycycline in combination with either streptomycin or rifampicin, Lyme disease, respiratory and dental mycoplasma infections, destructive or refractory periodontal disease, exacerbation of chronic bronchitis, especially against Haemophilus influenza, leptospirosis, in which the patient actually is allergic to hypersensitivity. Another alternative that we can actually give is erythromycin. Now, the two common drugs that we'll talk about are doxycycline and tetracycline. So here's the therapeutic applications. So we can use this against the different organisms that are listed here and the different conditions that are listed there. So you can take your time to actually pause the video at this point and just pretty much read through. Because if I read through each and every one of them at this point, you already have an idea of the organisms that may fall under each group. So it would make this video unnecessarily long. So here we'll start with tetracycline. The dose is about 250 milligrams every 6 hours. So it means we can give this 4 times a day. We can increase this to 500 milligrams 3 to 4 times a day. Then in non-gonococcal urethritis, we give this at 500 milligrams every 6 hours. That's 4 times a day for 7 to 14 days. We can actually go up to 21 days if there is failure or relapse after the first course. The route of administration can be given orally. There is also a preparation for eye drops, which is about 0.5 to 1%. We can use this in acne, acne vulgaris, amoebiasis, bacterial infections, brucellosis, conjunctivitis, endocarditis, long-term healed gastroesophageal reflux disease, gastric ulcers due to H. pylori, pneumonia, syphilis, trachoma as an adjunct therapy, as well as an alternative drug in respiratory and urinary tract infection. This drug is not recommended for infants, children, and pregnant women unless if the benefits outweigh the risks. Then, of course, there is a side effect of hepatotoxicity, anaphylaxis, and other things like nausea, diarrhea, skin reactions, stomatitis, vaginitis, and glossitis. There's also an increase in blood urea. This drug is contraindicated in patients with systemic lupus erythematosus, renal disease, and hepatic disease. Now, moving on to doxycycline, this can be given as 200 milligrams on the first day, then 100 milligrams once a day. For severe infections, we can use 200 milligrams every day, or 200 milligrams once a day. For early syphilis, 100 milligrams twice a day for 14 days is enough. For late syphilis, 100 milligrams twice a day for 28 days, and for neurosyphilis, 200 milligrams twice a day for 28 days. If you get uncomplicated genital chlamydia or non-gonococcal urethritis, 100 milligrams twice a day for 7 days and 14 days for PID would be enough. The route of administration is oral. Indications include acne vulgaris, anthrax, genital urinary tract infections, GIT infections, Plasmodium falciparum. We can also add this drug, pneumonia, respiratory tract infections, as well as sinusitis. It's contraindicated also for patients with hypersensitivity and SLE and should be avoided in pregnant women and pediatric patients. Now, side effects include staining of the teeth, especially in children with developing teeth, hypoplasia of the enamel, pseudomembranous colitis, anaphylaxis, liver damage, anorexia, flushing, and tinnitus, which is this ringing sound in the ear. Moving on to the next group of drugs, which are the aminoglycosides. These are pretty much going to be used to treat these serious infections which are caused by aerobic gram-negative bacilli. So these drugs are also bacteriostatic in nature, but at much higher doses, they can actually be bactericidal, so they can kill the organisms. They are very effective against your Pseudomonas aeruginosa. Remember that when you get a Pseudomonas infection, it will give you this greenish discoloration. So when you see this greenish discoloration, you should add at least an aminoglycoside to your regimen. Then you may have Klebsiella, also pneumonia, and Enterobacter species. Then when they are combined with beta-lactam antibiotics, they work synergistically against Enterococcus fecalis, Enterococcus fecum, infective endocarditis. Then, of course, some common drugs include gentamicin, streptomycin, and amikacin. These drugs are notorious for causing ototoxicity, meaning that they cause damage to the cochlea, to the ear. They are also known to cause nephrotoxicity. They can potentiate renal failure, and they should be used with caution in patients that have renal failure. They can cause neuromuscular paralysis as well as allergic reactions. Now, the side effects are mostly dependent on the dose, so at all times, whenever possible, make sure that this person doesn't go beyond 7 days and they are receiving the right dose. These drugs are not given in patients that have other drugs that can potentially be ototoxic, like furosemide, which is a diuretic. So here's a therapeutic applications. We can give it in tularemia. It has a synergistic activity with beta-lactam, and these are the organisms to which these drugs can target. So keep this in mind. You can actually pause the video at this point and have a look at these therapeutic applications. So we begin with gentamicin. So this is a broad spectrum activity, but it's quite inactive against anaerobes. It has a poor activity against the hemolytic streptococci as well as pneumococci. That's why it's often combined with your penicillins or your cephalosporins. Then when you're using it in blind therapy on undiagnosed serious infection, then like I said, we combine it with penicillins and also metronidazole, or you can combine them with both gentamicin, penicillin, and metronidazole to at least target everything that you are going to be looking at. Your penicillins will be targeting your gram positives. Your gentamicin will be targeting your what do you call this? Your Pseudomonas. Then your metronidazole will be targeting your anaerobes. Then your indications include septicemia, neonatal sepsis, meningitis, and other CNS infections. You may have biliary tract infections, acute pyelonephritis, prostatitis, endocarditis, and you must combine it, of course, with other drugs. Then, of course, hospital-acquired pneumonias. Then it's contraindicated in pregnant women, in patients with renal dysfunction, in geriatric patients, that's old patients, as well as patients with hypersensitivity. Here's the dosage. 3 to 5 milligrams per kg daily in divided doses every 8 hours. So in 3 divided doses. Then of course you should not exceed 80 milligrams if you're combining it with ampicillin. Then let's say if you're using ampicillin at a dose of 1 to 2 grams. Then of course this can be done for prophylaxis against bacterial endocarditis. In neonates we give it at 2.5 milligrams per kg 8 hourly. We can also give it topically as eardrops or eye drops. That's about 0.3%. We can give it IM. We can also give it as IV. Then streptomycin is used in bacterial infections. It can be used in tularemia. It can also be used in TB. It's contraindicated in patients with myasthenia gravis, renal disease, as well as ear infections. And we shouldn't give this drug to pregnant women. We shouldn't give it to lactating mothers. We shouldn't give it to pediatric patients unless if the benefits outweigh the risks. And of course, the dosage in adults is 15 milligrams per kg with a maximum of 1 gram daily. Then 150 milligrams once a day orally can be given. 115 milligrams per kg every 12 hours in children or neonates can be given. Route of administration can be given orally. It can also be given as intramuscular injection. And of course, amikacin is the last drug that we'll talk about in this group. It can be used in serious gram-negative infections that are resistant to gentamicin. So it's used in conditions like burns, cholangitis, endometritis. It can be used in heart failure, infections in neutropenic patients, meningitis, mycobacterium infections, neonatal infections, peritonitis, respiratory tract infections, even supraventricular tachycardias like atrial fibrillation, urinary tract infections. This drug also should be avoided in pregnant women, geriatric patients, and in neonates. The dose is 15 milligrams per kg in 2 divided doses. You can increase to 22.5 milligrams per kg daily in 3 divided doses in severe infections, a maximum of 1.5 daily for up to 10 days. That's the max that you should go. 7.5 milligrams per kg in 3 divided doses in neonates and 2 divided doses in pediatric patients can be given. And of course, your route of administration is intramuscular injection or IV. Next group of drugs is of course the macrolides, which just like the previous group of drugs are also bacteriostatic, but at higher concentrations can be bactericidal. Common drugs include erythromycin, clarithromycin, and azithromycin. So erythromycin is quite effective against many organisms, similar to penicillin G, so it can be used as an alternative to patients that are allergic to penicillins. Clarithromycin is similar activity to erythromycin, but also effective against Haemophilus influenza, chlamydia, legionella, moraxella, and even ureaplasma species and H. pylori. So it's used also for eradication of H. pylori. Azithromycin is effective against Haemophilus influenza, moraxella catarrhalis, and it's the preferred treatment of urethritis caused by chlamydia trachomatis and mycobacterium avium. So indications include things like respiratory infections, whooping cough, Legionnaire's disease, as well as Campylobacter enteritis. So we'll begin with erythromycin. So some indications include it can be used as a substitute for patients that are allergic to penicillins, oral infections, Campylobacter enteritis, syphilis, non-gonococcal urethritis, respiratory tract infections, including Legionnaire's disease, skin infections, chronic prostatitis, prophylaxis of diphtheria, Group A streptococcal infections, whooping cough, acne vulgaris, bronchitis, even ear and GIT infections. Side effects include prolongation of the QT interval, which can predispose someone to develop certain arrhythmias, hepatic impairment, abdominal discomfort. This causes Stevens-Johnson syndrome and toxic epidermonecrolysis, and as well as some allergic reactions. Some dosages include 500 milligrams to about 1 gram 6 hourly, so you can give this 4 times a day, IV, or 250 to 500 milligrams 4 times a day orally, or 500 milligrams to 1 gram 2 times a day every 12 hours. Or you can give up to 4 grams in divided doses for severe infections, 50 milligrams per kg infusion continuous or in divided doses every 6 hours for severe infections, and 25 milligrams per kg daily for mild infections. And of course, route of administration is orally and IV. Then, though I haven't seen the IV commonly, but the oral formulation of commonly being seen in the hospital. So this can actually can be given with caution in pregnant and lactating mothers. Then of course with azithromycin, which is one of the drugs that was commonly Googled and commonly abused during the pandemic, this is used in management of respiratory tract infections, otitis media, skin and soft tissue infections, uncomplicated genital chlamydia infections, non-gonococcal urethritis, mild or moderate typhoid due to multiple bacterial resistant organisms. This is of course an unlicensed indication, prophylaxis of group A streptococcal infections. So this should also be used with caution in pregnant and lactating mothers. It shouldn't be used in patients with hepatic impairment. Then of course it has a similar profile to erythromycin. The dose is about 500 milligrams once a day for 3 days, or this is supposed to be 500, not 50. 500 milligrams on the first day, then 250 milligrams once a day for 4 days in adults. I think let me just change this to 500 because I'm going to be posting this much later on. So 500 milligrams on the first day, then 250 once a day for 4 days in adults. And then if you have uncomplicated genital chlamydia infections or non-gonococcal urethritis, 1 gram, you can give it as a single dose. With typhoid, 500 milligrams once a day for 7 days. This is an unlicensed use. And of course, this is given orally. And clarithromycin, the indication is going to be respiratory tract infections, mild to moderate skin infections and soft tissue infections, otitis media, and H. pylori eradications. Then this should be used with caution in patients with renal impairment, pregnant, as well as breastfeeding mothers. It also has similar side effect profile to erythromycin. So orally, it can be given orally or as an IV infusion. If you're giving it as an IV infusion, this should be in a large proximal vein. So it can be given at 500 twice a day, but if what I've commonly seen being used as the oral formulation, which is 250 milligrams every 12 hours for 7 days, 500 milligrams up to about 14 days for severe infections, and of course 7.5 milligrams every 12 hours in children. We move on to the next group of drugs, which are the lincosamides, clindamycin. So this is used to treat gram-positive organisms and anaerobic bacteria. So this is the drug that's going to be used to treat staphylococcal bone and joint infections, peritonitis, falciparum malaria, acne vulgaris, bacterial infections, bacterial vaginosis, endocarditis, dental infections, pelvic infections, septicemia, and even some soft tissue infections. Side effects include diarrhea, abdominal discomfort, Stevens-Johnson syndrome, and toxic epidermal necrolysis, thrombocytopenia, taste disturbances, GIT, symptoms like esophagitis, nausea, vomiting, antibiotic-associated colitis, and jaundice. Of course, this should be avoided in neonates and pregnant mothers. It should be avoided in patients with renal and hepatic involvement. It can be given orally, can be given as a deep IM, intramuscular injection, or an IV infusion. If you're giving it orally, 150 to 300 milligrams every 6 hourly. You can give up to 450 every 6 hourly. That's 4 times a day in severe infections. And in adults, use 3 to 6 milligrams per kg in children. Then deep IM or IV can be given at 0.6 to 2.7 grams daily in 2 to 4 divided doses. For severe infections, you can go up to 4.8 grams daily. Then single dose above 600 milligrams must be given by IV only, and a single dose infusion must not exceed 1.2 grams. The next is linezolid, and this that I'm not going to pronounce. So this covers against some gram-positive cocci like Enterococcal fecalis, including those that are vancomycin resistant, Enterococcus fecum, including those that are vancomycin resistant strains, Staphylococcus epidermidis, Staphylococcus aureus, including those that are methicillin resistant strains, Staphylococcus hemolyticus, Streptococcus pneumoniae, viridans. So you won't see this drug being commonly actually prescribed because you are reserving this for those very, very resistant cases. Then you also have gram-positive bacilli like Corynebacterium species, Listeria monocytogenes, anaerobic organisms like Clostridium perfringens, others like Mycobacterium tuberculosis. This is not so effective against most if not most, gram-negative organisms, it's not so effective. Then it should be used with caution in patients that are pregnant, as well as patients that have hepatic and renal dysfunction, as well as psychiatric patients, because it may result in also hematological disorders. So make sure that you're doing your full blood counts at regular intervals, because it may cause thrombocytopenia, anemia, leukopenia, and pancytopenia. So the dose is 600 milligrams every 12 hours, that's twice a day, usually for 10 to 14 days. A maximum duration of treatment is 28 days, or 600 milligrams every 12 hours as an IV infusion over 30 to 120 minutes. So it can be given IV or orally. Moving on to another group of drug, which is chloramphenicol. This is a potent broad-spectrum antibiotic. It's going to be associated with serious hematological side effects. So it's reserved for these life-threatening infections that are due to Haemophilus influenza and typhoid, though there is some resistance that has been noted with typhoid, and we'd rather use the fluoroquinolones to treat patients with typhoid fever. So the route of administration includes oral, IV injections. You can give infusion. You can also have a topical preparation, 5 to 10%, 6-hourly eye drops. So the dose is going to be 50 milligrams per kg daily in 4 divided doses. You can double the dose in severe infections like meningitis and septicemia. You can also give 500 to 50 to about 100 milligrams per kg. Then this should be used with caution in patients with hepatic and renal dysfunction and in neonates, and we should not use this in pregnant and breastfeeding mothers. Side effects include things like aplastic anemia, peripheral neuritis, optic neuritis, Gray syndrome where you have abdominal distension, palate cyanosis, as well as circulatory collapse. And moving on to the fluoroquinolones, remember that these are going to pretty much enter into the bacterium through a channel which is known as a porin channel. Then, of course, they're going to be exerting their effect by pretty much going and affecting the DNA gyrase, which is also referred to as bacterial topoisomerase 2, as well as bacterial topoisomerase 4. Now, when you inhibit the DNA gyrase or bacterial topoisomerase 2, remember that this is going to cause relaxation of the supercoiling of the DNA. So the DNA will be relaxed. This will also promote the DNA to be broken down easily. And of course, if you inhibit the topoisomerase 4, this is going to be causing chromosomal stabilization to be affected, especially during the cell division, therefore interfering with actually separation of the newly replicated DNA. So this is going to be effective against E. coli, Pseudomonas aeruginosa, Haemophilus influenza, atypical organisms like Chlamydia, as well as Legionella, which are these two families, then gram-positive streptococcal infections, and some mycobacterium like Mycobacterium tuberculosis. So they are not used in the treatment of Staphylococcus aureus or Enterococcus infections. They're not effective against gonorrhea, and some actually may be used in community-acquired pneumonias. That's why we refer to them as respiratory fluoroquinolones like levofloxacin and moxifloxacin. So they can also be divided into generations, quote unquote. The first generation is nalidixic acid. This is supposed to be a C. The second generation type of fluoroquinolone is ciprofloxacin. The third generation is levofloxacin. The fourth generation is moxifloxacin. So these drugs are generally well tolerated, but some common side effects include things like nausea, vomiting, diarrhea, headaches, dizziness, or lightheadedness. So here's the therapeutic applications of fluoroquinolones and the different organisms to which they target. Take your time to actually pause the video and actually look at this. We'll start with nalidixic acid. So this is the first generation quinolone. It can be used in uncomplicated UTIs and some GIT infections. We give it at a dose of 1,000 milligrams 6-hourly. That's about 4 times a day. Then, of course, pregnant women should not receive this drug. It can cause cholestatic jaundice, thrombocytopenia, hemolytic anemias, photosensitivity, and anaphylaxis. Our second generation cephalosporin is your ciprofloxacin, which is another commonly used drug. Can be given IV or orally. IV, the usual dose is 100 to 400 milligrams twice a day. Orally, can be given at 250 to 750 milligrams 2 times a day. Rather, I don't know if I said 4 times, but it's supposed to be 2 times BD, 2 times a day. Then it can be used in respiratory tract infections, where it can be given 250 to 750 twice a day orally, or urinary tract infections 250 to 500 twice a day orally, or gonorrhea 500 milligrams as a single dose orally. In Pseudomonas lower respiratory tract infections, we can give 750 milligrams twice a day orally, and then most infections would actually just require 500 to 750 twice a day. We can actually give this also for surgical prophylaxis. Then You can give an IV infusion of 200 to 400 milligrams twice a day, or 100 milligrams as a single dose in gonorrhea as an IV infusion. Then some side effects include flatulence, pain, and phlebitis, especially at the site of injury. Levofloxacin is a third-generation quinolone, which is going to be used in acute pyelonephritis, bronchiolitis, prostatitis, complicated UTIs, urinary tract infections, folliculitis, nephrogenic and partially pituitary diabetes insipidus, otitis externa, pneumonias, pyelonephritis, as well as respiratory tract infections. It can be given orally or IV. Orally, if we're giving it orally, 250 to 500 milligrams twice a day, or 500 milligrams twice a day. It also prolongs the QT interval, so predisposes to arrhythmias, hypoglycemia, and peripheral neuropathy. Moxifloxacin is another fourth-generation cephalosporin, which can be used in community-acquired pneumonias, sinusitis, exacerbation of chronic bronchitis, which of course has failed to respond to other antibacterials. So this should be given at 400 milligrams once a day for 10 days for community-acquired pneumonia, 5 to 10 days for exacerbation of chronic bronchitis, and 7 days for sinusitis. It can exacerbate arrhythmias, cause flatulence, constipation, palpitations, angina, and vasodilatation. Then we'll move on to the next group of drugs, which are pretty much the antimetabolites and drugs that are going to be inhibiting DNA synthesis. So pretty much we have inhibitors of folate reduction. So their use has decreased due to increasing resistance. We have a drug that's known as trimethoprim, which can be used in UTIs, acute and chronic bronchitis, pneumocystis pneumonia. Then the dose is 200 milligrams every 12 hours orally, or 300 milligrams every 24 hours. Side effects include vomiting, depression, psychosis, mania, and facial edema. Then you can combine some of the inhibitors of folate with the inhibitors of folate reduction. So you have a drug that's known as Ceftriaxone or cotrimoxazole. It's a combination of two drugs, trimethoprim and sulfamethoxazole. So pretty much the trimethoprim is going to be, or this drug is going to be inhibiting synthesis of tetrahydrofolate. So the sulfamethoxazole is inhibiting the incorporation of PABA into dihydrofolic acid precursor. Then the trimethoprim is going to be preventing the reduction of dihydrofolate into tetrahydrofolate. So this can be used for urinary tract infections, respiratory tract infections like PCP, or which is now referred to as pneumocystis jirovecii, toxoplasmosis, and ampicillin or chloramphenicol resistant salmonella infections, and it has some activity against methicillin resistant staphylococcus, as well as community acquired skin and soft tissue infections. Now this is a very common drug that's used especially in prophylaxis of infections in HIV patients. A side effect of this is that it causes Stevens-Johnson syndrome and toxic epidermal necrolysis, GIT related symptoms, hyperkalemia, megaloblastic anemia, leukopenia, and thrombocytopenia. The dosage, if you're giving it orally, 960 milligrams every 12 hours. If it's an infusion, 960 milligrams every 12 hours. You can increase to 1.44 grams every 12 hours in severe infection. Then PCP prophylaxis, you can give it at 960 once a day, or you can reduce it to 480 as tolerated, or 960 on alternate days, so 3 times a week. Or you can give it at 960 twice a day on alternate days, three times a week, basically. Here are the therapeutic applications of cotrimoxazole. This is cotri, not cotro. Cotrimoxazole. Okay, you can pause the video at this point. Then you have some urinary tract antiseptics, which is nitrofurantoin, which is both bactericidal and bacteriostatic to many gram-positive and gram-negative organisms, including E. coli, Staphylococcus pyogenes, Streptococcus pyogenes, Aerobacter aerogenes, then of course Paracolobactrum. Then of course it has no systemic antibacterial effect, so it's only used for urinary tract infections. It inhibits the synthesis and actually it inhibits various enzymes and damages the bacterial DNA. So its main use, of course, is urinary tract infections. So it should be used with caution in patients who have anemia, diabetes mellitus, and electrolyte imbalances. Side effects include acute and chronic pulmonary reactions, peripheral neuropathies, hypersensitivity. Of course, it should be avoided in women at term and those that are breastfeeding. For uncomplicated UTIs, you can give 50 milligrams every 6 hours with food for 7 days. So 3 days usually is adequate in women. Then severe chronic infections, 100 milligrams every 6 hours. So that's 100 milligrams 4 times a day with food. And you can reduce or stop if severe nausea happens. And then, of course, prophylaxis, you can give 50 to 100 milligrams once a day, pretty much at night. then I thought you thought I would forget this most important drug, which is metronidazole, also referred to as flagyl. This is it's a synthetic antibacterial, but it also has antiprotozoa activity. So it's effective against Trichomonas vaginalis, amoebiasis, yardiasis, and is one of the most effective drugs against anaerobic bacteria. So it's both bactericidal, amoebicidal, and trichomonacidal, so it kills these things. It's going to be readily taken up by the anaerobic organisms and reduced to an active form which disrupts the DNA helical structure and inhibits nucleic acid synthesis in the bacteria, causing to cell death. So it can be used in Crohn's disease, it can be used in antibiotic-associated diarrhea, it can be used in acute dental infections, dysentery, giardiasis, PID, it can be used in urogenital trichomoniasis, amoebic liver abscesses, bacterial vaginosis, Helicobacter pylori infections, oral infections, especially as an alternative to penicillin-sensitive patients. It should be used with caution in, patients that are pregnant and breastfeeding mothers. They should not use this unless if the benefits outweigh the risk, but they shouldn't use this drug. It's contraindicated in patients with liver damage and blood dyscrasias, as well as patients that have seizures, because some of the side effects include encephalopathy, convulsions, GI absent, metallic taste, dry mouth, as well as gynecomastia. It can be given as an IV, orally, or a topical preparation. Then the dose, of course, is going to be roughly around IV. You can give it 500 milligrams 3 times a day. Orally can be given 400 milligrams twice a day or 3 times a day. Then in children or neonates, you can give it at 7.5 milligrams per kg. 8 hourly. So I really hope that shed a lot of light when it comes to antibiotics, and the next time that you see these antibiotics being prescribed, you have an idea of the dosage, the indication, and why these antibiotics are being given. If you learned a lot, please drop a like, hit the subscribe button, hit the bell notification icon to be receiving notifications every time I post such videos. Drop a like, drop a comment. Until next time, my name is Dr. Moses Kazevu. Bye-bye.